Debulal. Now we'll have Mudit to tell us about the real world experiences about Brolucizumab. You see, the thing is, if you have a better drying agent and if the duration also is good, Farsimab is on its way. Farsimab will land in this country around October and November. And till such time, therefore, I told Debulal, why should be shyness be there? So let's hear from this young man from LV Prasad.
All right. So good afternoon, and first of all, let me thank AIOC, the scientific committee, and the chair of this session, Dr. Lalit Verma, for giving me the chance to speak about our experience with Brolucizumab. Now, I have no other financial disclosures. Now, before I go ahead, we already know that protocol T, which was the first comparison or study which compared head-to-head DME with three anti-VEGF agents, which compared aflibercept, bevacizumab, and rituximab, showed us basically that if you look at eyes which had a good visual acuity to begin with, all of the three compared well to each other. But eyes with a visual acuity of 20/50 or worse, it was there that aflibercept scored better and had a better effect in terms of improvement in retinal structure as well as in terms of improvement in visual acuity. What we also know is that in spite of it, in all of those studies, and there was an analysis where they tried to analyze the eyes which had a persistent macular edema even after 2 years of treatment, and 29% of eyes with aflibercept, more than 50% of eyes with bevacizumab, and more than 30% something with ranibizumab also had a persisting DME. Now, what do you mean by that? There is no specific definite accepted definition of recalcitrant or persistent DME otherwise. But what we do know is that an inadequate response to a combination of laser, steroids, or any anti-VEGF therapy, and refractive DME was defined as central retinal thickness greater than 300 microns or a reduction less than 10% after at least 3 prior anti-VEGF injections. Why do we get this in our practice? Why do we have patients who may have a recalcitrant DME in spite of all that we are treating them with? And there are no specific single answer. There are multiple reasons for that. You may initially actually have just a ceiling effect. The patient had a good visual acuity to begin with. Inadequate treatment, and by that I mean either not long enough or not often enough. And we have just had previous talks which have showed where Dr. Anirudh Maiti also showed the importance of treating these patients aggressively from initial inset. Systemic factors, we know diabetes is a complex disease. It's not just ocular features but glycemic control, hypertension, all of them come into play. Non-VEGF pathways like inflammatory mediators, delay in treatment response, and then structural changes. Dr. Ramesh Venkatesh very nicely showed the OCT biomarkers which can have an importance in prognostication in cases of DME and post-vitrectomized eyes. So what were we doing for these patients till now? We either did focal laser, switched to other anti-VEGF agent, or resorted to intravitreal steroids like dexamethasone implant or fluocinolone acetonide implant, something which we don't have access to at this point of time. But now we have one more molecule, which is a single chain antibody fragment. We have already seen multiple cases, and I'll be showing you some more cases of it. And why does this probably work better than other conventional anti-VEGF agents that we have had till now? And the reason is that it has got a more VEGF binding ability per volume. The molecular weight is the lowest, 26 kilodalton. It has got a higher affinity for VEGF-A, and it has got a more effective tissue penetration. Now, all of those basically translate into a much better outcome in a lot of our patients. And there are studies which have shown that it penetrates the retina rapidly, and these are preclinical studies which showed the outcomes over here. Now, the Kestrel and Kite studies which compared brolucizumab with aflibercept showed that in both these studies, brolucizumab did score better in terms of duration of treatment-free interval as well as in terms of improvement in vision and reduction in retinal thickness in terms of intra and subretinal fluid. Now, one of the apprehensions which we have always had till now probably, and we just had a discussion just 2 minutes back prior to this talk about this apprehension regarding inflammation which was happening, but we are not seeing that in our patients as much as what we feared earlier. So now comes what can we do for these cases. We already spoke of focal laser switching, but now like I said, we have another agent called brolucizumab, and we explored this in our recalcitrant DME. Now Dr. Lalit Verma sir just said about our probable use of this now in even treatment naive patients. Honestly, till now I have not tried it in my treatment naive patients, but I have tried it in a lot of my recalcitrant cases, and we have had some surprisingly good outcomes in a lot of these patients. Let me show you a few of these. So this was one patient who had presented to us a visual acuity of 21, 20 and 20/80 in the right and the left eye, had received 4 injections of bevacizumab earlier, was treated with every possible conceivable agent that we have at our armamentarium in terms of micropulse laser, 3 injections of Dex implant in right eye, 2 in the left eye, modified grid laser, IVTA, 1 injection of zivaflibercept also. But since the patient was not improving, we resorted to the use of intravitreal brolucizumab. And look at the left eye. The left eye edema is resolved significantly. Right eye initially was still persisting, but post 4 injections, this is how the visual acuity is. It is improved to 20/80. There were no adverse events. It's at this stage that the patient refused to take further injections, but the visual acuity improved for the first time over years in this patient. Another patient, again, history of multiple injections of ranibizumab and dexamethasone implant, and subsequently post injections over there, this is how the patient's visual acuity was improving to 20/30 in the right eye, 20/60 in the left eye, treated with 3 injections of brolucizumab, and this is how the final visual acuity was 20/30 in the right eye. Left eye, which also had structural changes, hard exudates, subfoveal exudates over here, hyperreflective dots, also improved to 20/40, and that was possibly the best vision that we have been able to achieve for this patient in spite of the patient being on treatment for the last 4 years with us. Patient underwent a phacoemulsification in the left eye. The edema recurred in the left eye again, but post injection subsequently now the patient maintains a visual acuity of 20/30 and 6 in both the eyes. And this is the third case which I actually wanted to show. This was a school teacher who had 2500 vision in the left eye, ischemic macula, unlikely to improve, but the right eye had a visual acuity of 20/60. This was how the right eye was initially after 1 injection. Subsequently, the structural changes started regressing. The fluid went away, reduced from what it was earlier. The patient was lost to follow for a few months, came back, we re-injected, and post 6 months, the patient was maintaining a visual acuity of 20/30. This is the first time that the patient had a visual acuity of 20/30 in the right eye, which is the better eye of this patient. 9 months again, visual acuity maintained. The patient came back with worsening after 12 months, or that is 3 more months later, with a visual acuity of 20/200, got the 4th injection, and over here again the visual acuity improved to 20/30, maintained at 20/30 another few months, comes back with a recurrence at 15 months, that is 4 months after the injection. At this stage, this is the case I was discussing about. Patient comes back with increased AC inflammation. No hypopion, but increased AC inflammation. And like I said, this patient had a history of having taken a Covishield vaccine 2 weeks back. We have had patients who had a AC inflammation post Covishield vaccination also, so we could not attribute it or pinpoint it to one of the two. However, we kept the patient under observation. The patient's inflammation resolved with just topical steroids. Patient now maintains a visual acuity of 20/30, has had 1 more injection, and now even after that, at this point of time, the patient maintains a visual acuity of 20/25. So this is how brolucizumab is working in a lot of our patients. It offers a ray of hope in recalcitrant DME. And I think as retina specialists, we are now living in very exciting times where we are getting more and more newer molecules. Faricimab is on the horizon. Same holds true for the increased dose regimen of aflibercept. And I think we now have multiple options of taking care of our patients and taking better care of